All right, excellent. So when asked to speak tonight, the magnitude of the conversation and the topic can be pretty overwhelming. So I wanted to steal from a presentation I gave recently through the Center to Advance Palliative Care to really set up what is a conversation and how we can change the world by looking at what it means to live, what it means to age, and our lives. I'll just jump right in. I am a palliative care physician, and I want to talk about what true palliative care is and how we kind of shift the mentality to achieve this, not just in healthcare, but in our daily lives, so that we can live and love and learn and grow through every breath we take. This conversation tonight is not about dying, not about death. I can't change that. You can't change that. That is an inevitable line in the sand, one which I honor and I respect. But the real conversation is, what is sacred to you as a human being as you approach that line, given whatever you're dealing with, from a medical perspective or otherwise. And so this is really tailored around that point specifically. So discuss key elements of palliative care and move on actually to the subtext of the conversation. If I think about the morning of September 3rd, when I awoke early, about 4:50 in the morning, and I was at my parents' house, the home that I grew up in, and you know, the smells and the sounds that are one's childhood home embed us with deep-seated memories. And there's something that inexorably ties us to our beginnings and our past and what has made us who we are. As I walked down the hallway and I felt the familiar carpet beneath my feet and the cool transitioning air outside from summer to fall, I stopped right before I got to my parents' living room. We were caring for my mother. And I flashed back to a conversation I had had about a week to 10 days before with my father. And he said, "Tim, is this 6 months? Is it a year? What do you think?" I said, "Dad, we're looking at days to a week." My mom had been dealing with progressive lung disease and dementia. And again, the inevitable was inevitable. So I paused and reflected on what I will call is the gift that we all need to empower each other with, and that's the gift of courage. To walk to our respective horizons and look into the abyss, hopefully find new truths, self-reflection and growth, and to be able to take those truths back, apply them to our lives, share them, listen to, hear, and learn from other individuals' truths so that we can live. From that moment on, I walked forward to my mom's bedside. We were caring for her in our living room. And I ceased to be a father of three, a physician, 48 years old. I was little Timmy. I was 7 years old with a teddy bear. I knew she had died. But I did the thing that good son doctors do. I felt her wrist for a pulse that I knew wasn't there. And then I found myself placing my head on her chest. And what I thought intellectually was to listen for a heartbeat. And 7 months later, I realized I was standing on yet another abyss, another horizon, staring out at the abyss, and I wanted my mom to just hold me, reach up and hug me and tell me that it was going to be okay. How do we have the courage to come to that space? How do we have the courage to talk about what is inevitable. And that's where I'd like to take the conversation and look at what is the subtext of our journeys, and how do we move forward knowing this inevitability. So I will ask, how many of you in the audience, and I'll need some guidance from whoever can speak to me, how many of you have ever been to Amsterdam? I hope there's a few people raising.
We've got probably at least 20 people with their hands up, if not more.
I don't want to know why you've been there, okay? I've done a lot of work in Tanzania, and Amsterdam is the halfway point. And in Amsterdam is the Rembrandt Museum, and this is a self-portrait of Rembrandt. He was a Dutch painter during the Renaissance, considered a master. Italians describe this type of painting as chiaroscuro, which means light out of darkness. And when I've seen this self-portrait, whether it's March or October, sunny, rainy, morning, night, I stand there and there's a tremendous sense of value. The color palette, the brush stroke is truly amazing. But it is, at the end of the day, static. It doesn't change. It reflects back to me exactly what it is, and that is a self-portrait of Rembrandt. This is, at a very high level, what healthcare is. It is a linear algorithm. It is static. It is how many of us try to live our lives. It is a known entity. It is defined and siloed. It is something that is consistent and never changes. I'm going to ask another question. How many people have been to the Museum of Modern Art in New York City?
Again, about 20 plus people. Lots of people out of about 100. We got 100 people looking at you right now.
When I go to the Museum of Modern Art in New York City, and again, same scenario, if it's October or March, morning, night, sunny, rainy, perhaps a little hungover, and I stand in front of this particular painting, and we just lost. Sorry. There we go. This is a painting by Jackson Pollock, and it's called Convergence. And every time I stand before this, even if it's several times during the same visit, it is not static. It is ambiguous at best as a painting, but what it represents to me is the algorithm of life. When I stare into this painting, what's reflected back on me is who I am at that particular moment in time. What is it that I hold sacred? What is it that I value? What are my experiences in the context of what has come before? This is ambiguity. This is facing the unknown and embracing living, loving, learning, and growing. This is how we get to courage. It is embracing this that allows us as human beings, as goofy country physicians, such as myself, and anyone else on the planet, to take those steps towards our horizon, to see what those truths of life are and allow us to really embrace them and live them. I think the whole key to this conversation, the whole key to rectifying a healthcare system that is broken when it comes to supporting the sickest of the sick, the most vulnerable patients, and that's the palliative medicine. We need to transition from Rembrandt to Pollock, because Pollock is the real chiaroscuro. It's a real light out of darkness. It helps us overcome our fears, our sense of the unknown. Embracing ambiguity allows us to have a sense that we can control an uncontrollable situation. And so this is the fulcrum upon which everything I do exists. And if there's one message I can leave you with tonight is to appreciate Rembrandt, because there's value. At 48, if I drop to the floor clutching my chest, you know, I want a linear algorithm to say it's not a heart attack. It's just something he cooked himself and ate, and that's why he feels like he's dying. But that does not work for the population that is growing exponentially in this country and is suffering, and they're stealing from within the healthcare milieu because we try to fit him into a Rembrandtian profile, and it doesn't work. When we're able to give someone the gift of courage through a conversation, embrace our ambiguity and their ambiguity, courage, as defined by Webster, is having the strength, fortitude to overcome one's fears, in particular death and dying. I found it very interesting. Once we come to this space and talk about it, and take away that I can't change the outcome regardless of what you're dealing with, I can change the journey predicated on what's sacred to you, we're able to face the fear of the closet monster, and collectively we can turn the light on and we can conquer those dragons. By embracing that ambiguity, we are recreating what's been lost over the last century, and that's a true sense of community. So I care for you not because you're a patient, but because you're a human being. And we have a shared experience called life. So collectively we stand, turn the light on, and we see that there is no closet monster, and we can move forward together. So how does this fit into the bigger concept of, the actual practice of medicine? There's a philosophical foundation, but how does it translate into, data and metrics, and how do we make what I always cringe when I say the financial case for changing our healthcare system? You have to understand a little background that we are in a system presently that was developed in the 50s, post-World War II. And it's predicated upon doing things to people rather than for them and with them. Back in the 50s, that was fixing a broken leg, having a baby. Today, it's dealing with people who have progressive, irreversible, often fatal, multiple complex disease entities. And we are treating them with things that didn't exist back then. We're identifying them in ways that didn't exist back in the 1950s. So the healthcare system was built, and the model is one that does not support caring for this population. We know that presently, 15% of the population of the United States of America utilizes about 85% of all healthcare dollars. 5% of that uses 50%. So we have 5% utilizing 50%, 15% of the people using 85% of the healthcare spend. That translates into just under 20% of the gross domestic product of the United States of America this year. Last year, it was about $3.7 trillion. What we also know is that a significant amount of that resource has no value if we define value as increasing one's length of life or the quality of one's life. Again, we do a lot of things to people, but we rarely do them for or with them. So set the stage. Right now, 20% of the GDP, if we know that over the next 2 decades, 10,000 Americans a day are going to join this sandbox. It's the baby boomers. And following the linear algorithmic model of medicine, in 20 years, we're looking at nearly 65% of the gross domestic product of the United States of America is going to be spent on a very small fraction of the population. Now, I always take a hard stop right here and with absolute certainty share that I'm not talking about withholding care. I'm not talk about allocating resources that you have, green hair so you can have X, Y, and Z. You have 6 toes on your left foot so you can have A, B, and C. Not at all. What I'm talking about is true informed consent. If you have X, Y, or Z, what isn't done ubiquitously in the healthcare system is to sit down and tell you what that means and to align your knowledge and your values with options of care. And so we look at 65% of the gross domestic product of the United States of America based on our current delivery model. It's not about healthcare. This is about global economy. It is not sustainable. And when we know that most of that has no value, we really have to ask ourselves, what the heck are we doing? Why do we need to transition from Rembrandt to Pollock? Here's why. When we change the conversation, when we empower people to understand what they're dealing with, good, bad, or indifferent, and align what's sacred to them with true opportunities of care, we have outcomes that change the absolute playfield. So in my last position, over several years, I cared for several thousand people, the sickest of the sick, from diagnosis. And not just the last few days, weeks, or months of life, we're talking 86, 90, 98 plus months out. 94% of the people I cared for never had to go to the hospital. Not because I stood in front of the emergency room, waving them away, but when we engaged with them and shared with them the reality that we're talking about tonight, and we said, help us understand who you are as a human being. What are your values? How do you want to live your life? And we aligned care mechanisms with that. We precluded a lot of fear. We knew what was going to happen. And so we stood side by side and walked with people, and they wanted to be at home. And they wanted to pee in their own toilet and sit in the lazy boy and watch Jeopardy and have their grandkids bounce on them. And that's okay. Let's do that. We reduced the number of people who were cycling through the system for symptom issues, social, economic issues, behavioral health issues. Again, we listened and we heard, and we aligned what was possible. We had availability 24 hours a day. Every patient I've ever cared for had my cell phone number. And while I didn't go to the bathroom for 2 years because we were so busy, there was value in providing that care because it was a shared human experience. And so this last one, 70% per capita reduction in expenditure. We provided more care congruent with what people truly wanted in real time. They lived longer, and their quality of life was better, with the highest patient satisfaction scores out of the entire Unity Point health system. And in addition, we had the most likelihood to refer to others coming from patients and families. So these conversations are not about dying, they're about living, and they empower hope. We have to be pragmatic about what we hope for. Is it a cure? If not, we need to tell the truth. Many of my colleagues said, my patient's not ready to hear this conversation. I don't want them to give up. We've proven just the opposite. If you empower someone with the truth, they know what they can fight for. And they do that with every breath, as do their families and their community. So we have competing platforms. We've got a healthcare system that does not offer up the truth. I cared for a dear friend in the Des Moines area. In her late 30s, 2 kids who are friends with mine.
All right, Dr. Ihrig, I think that we might have lost you here. Just a minute. Okay, you're back. That is good.
Are we okay?
Yeah, we lost you for a second, but you're back now, so the connection was just spotty.
So she said, here's the next 18 months of my life. I've been given a diagnosis of cancer. She said, Tim, I don't even know what cancer is. So we started there. And we said, okay, here's what cancer is. Here's what breast cancer is. Here's what your particular type of breast cancer is with genetic markers, etc. And she said, whoa, stop for a second. You mean that there's a chance I could die from this? I took a deep breath and I said, yes. Not to be mean, not to be curt, but there is a chance you could die from this. She said, I didn't know that. And I'm always taken back because how do we care for human beings if we can't tell them the truth? Or we choose not to tell them the truth. So we went through the litany of chemotherapy and radiation, bilateral mastectomy, total hysterectomy, and what all this meant and what the negative side effects may be with the chemo, what the statistics were for positive outcomes. And she said, who's going to tell me if things start to go wrong? I said, well, first and foremost, beyond what any goofy long white coat physician, including myself, may tell you, you have to absolutely trust and listen and hear what your little voice is telling you. Because it will, with absolute certainty, tell you where you're at on your journey. And if you're proceeding in a direction that's one you want to go, or maybe a direction you don't want to go, it's going to tell you the truth. And that needs to be reconciled with what you're hearing from the medical community. Because if it's not, it leads to angst and frustration and a decreased quality. And so we paused and I said, what is sacred to you? And she said her kids, her husband. She offered, when I said, what scares you? She said, I'm not afraid of dying, but afraid of that journey if it leads to getting dead. And again, the journey of the unknown, ambiguity. And we talked about that. I asked the same question to her husband and both of their parents. We said this is about partnership and transparency and taking it one day at a time and honoring that little voice and hanging, IV fluids and giving anti-nausea medicine at 2 a.m. so that you can get through the chemo if that's consistent with what you want to do. And so we talked about all of that, and then we broached the subject of the 50% of the human that is not medical, that is not physiologic. I said, we've only broached half of you. The other half is your emotional state, your spiritual state, religious, if you ascribe to religion. And we talked about sexuality and relationships and communication. Because if we don't include all of these things, we have separate halves of the human being and we become Rembrandt. We're static. We can't move forward regardless of the chapter in our lives. Our role is to have the courage to bring those two halves together so that we can collectively support each other moving forward. And so that was the conversation. Fast forward 24 months, successful treatment of this cancer, successful reconstructive surgery, a big party to celebrate life, to celebrate the reconstruction. It was only her girlfriends who were invited. The Well, I didn't get to participate, so I was a little disappointed, but it was still a celebration of life. And it's what's possible even when we're facing a horizon that's fraught with much danger and anguish and potential physical and emotional unknown. So the healthcare system is antithetical to that journey. Reimbursement models, ladies and gentlemen, we work in a fee-for-service industry. If I do something to you, doesn't matter if you need it, doesn't matter if the outcome's good, doesn't matter if I'm good at doing it, doesn't matter if I did it to you yesterday, I'm guaranteed to get paid for it. There's a conflict of interest, not that my colleagues are maliciously doing things to someone, but if we preclude the truth, if we don't come forward and say, you have a chance of dying from this, let's have an ongoing conversation that's fluid and dynamic through this journey and give you options of care, we are essentially maliciously doing to you because you don't know what the heck's going on. But from a societal standpoint, and look at my work in Tanzania where I have difficulty getting someone Tylenol, and so pain is at some level a cultural phenomenon. The conversation about how we live is equally a cultural phenomenon, and that they don't want to die any more than we do, but they have an acceptance of this inevitability. And so they embrace living through every breath, for the most part. I struggle with our society at times that if we fail to be on the cover of GQ magazine or Vogue, that we have failed. Or if we become aged and frail or have a disease, we've done something wrong. I'll guarantee you, I'm never going to be on the cover of GQ or Vogue. And I know that I'm going to get old. I feel it every morning when I wake up. And so society's vernacular is misaligned with the reality and inevitability of life. And when we bring that into the intensive care unit, we say we can just start dialysis, we can just start a ventilator, we can just start. We're avoiding the hard conversations and not prolonging life, but we're prolonging death. We have no common language to talk about this. We've seen a lot of things over the last decade. Death cafes, this and that, death this, death that. I want to change that to saying, let's talk about life. Death is what happens as we exhale our very last breath. Instantaneous. We live up until that point. But let's embrace that. Let's empower each other again to walk collectively to that horizon and learn and grow. So true palliative care, we are in our pre-adolescence as a subspecialty. And we had formal accreditation a decade ago. So we're accredited by the Board of Medicine as a specialty. And there's been a lot of palliative care shingles hung out in front of healthcare institutions and organizations without really understanding what it is, can, and should be. A lot of bias and ignorance came to the field at its inception from other specialties. I don't think it's out of malice, but rather ignorance and lack of experience. And so what it traditionally has been is come in and have the conversation so that someone can make a decision about you want to die in a hospital or die at home. I ascribe that true palliative medicine is about this conversation and philosophical platform we've been talking about tonight, and it expands the spectrum of current health beliefs, and it's a current model for population health. And that when I sat on the board, we looked at how do we care for a population, and most people divided it into pediatrics and adults. We need to bring forth a more nuanced conversation and understanding that there are subsections of people within each that have unique needs. And Rembrandt doesn't fit those needs. We need to understand that it requires community. And we can't own it all as a health system. We need to partner and listen and hear what scares other entities, long-term care facilities, other people, etc., and collaborate, put the focus on this conversation about living and caring for this population. We're in our pre-adolescence, we're walking at the coffee table, so now is the time to really define what's possible, and that's what many of us in the field are trying to do from a policy level, from an accreditation level, from a payer level. How do we align centers for Medicaid and Medicare? How do we look at accreditation to be able to hang a palliative care shingle? What is it that we're trying to achieve as far as value? So we look at healthcare partners, understanding each other, the scope of abilities, vision, goals, clinical, administrative, regulatory, availability. It's about developing relationships across the continuum, engaging, not being afraid to embrace that ambiguity. We have to let go of if A then B then C then D to come to this space and change the system, because the system's broken. We can't put another cog into it and hope that it gets us where we want to go. We have to understand our concerns and our fears as, a chief financial officer of an institution. They and legal representatives usually sit at the top of most healthcare paradigms, and the goal is to avoid risk. How can we avoid taking care of the sickest of the sick? Because we know they're expensive. I say we have to embrace Jackson Pollock, ergo embrace risk, so that we can truly care for the patient, just not care about them. And then we actually mitigate risk because we're going to walk that journey with them. You have to understand the history of the relationships of various entities and really understand what are the strategic starting points. I go around the country, coast to coast, and I've actually been asked to come to Australia this summer and present and talk to their major healthcare system about what are the strategic starting points for integrating this conversation horizontally and vertically in any healthcare system. And then how do we operationalize it? How do we take it from how are you today and translate that into a platform of care that is individualized and accessible one day at a time. So when we were running our accountable care organization in my last position, we were ubiquitous. We were accessible and integrated everywhere a patient could be, with the exception of Dairy Queen and Harry's Bar. And I was not able to get those visits reimbursed, which is disappointing. When we look at why it's important to be available, and offer the greatest clinical feat that I ever did against the backdrop of not being a very bright guy, was a new consultation with a woman named Sarah who had a widely metastatic, so a cancer that had spread well beyond her lungs, which was the origin of the cancer. And she was pretty debilitated as this disease was ravaging her body. And again, not to be mean or curt, I mean, she was dead. Her life expectancy was markedly limited. And she, when listening to her little voice, came to that conclusion on her own. And we talked about that. She said, I would like to try some chemotherapy to see if we can prolong my life somewhat, because what's most important to me is spending time with my family and my grandchildren. But absolutely. And so my involvement initially was to manage symptoms of pain and shortness of breath. A couple weeks in, after a round of chemotherapy, her functional status, so how she was able to just live her life, diminished significantly. And she said, I think this is my inflection point. I think this is where I need to stop this, because I feel it's going to hurt me more than and potentially help me. And I know we're not going to cure this. And a day or two after that conversation, she called me at 2 a.m. And she said, you know, Dr. Tim, this is Sarah. And I said, Sarah, are you okay? Are you having any pain? She said, no. You have any shortness of breath? She said, no. I said, is Frank there? And I hear there's a gentleman snoring right beside her. And so obviously, you know, he was asleep right next to her. She said, Doc, I just need someone on the phone. I need someone in this space. And subtextually at 2 a.m, this is when the closet monster is the fiercest. This is when that chasm of clinical reality to emotional reality, standing on that particular horizon, the abyss is so deep and dark and long. She said, I just need someone here, about acknowledging the human experience and her existence. And we chatted, and after a few minutes, she said, will you do me a favor? And I said, sure, what is it? She said, will you read me a story? And I chuckled. I said, well, you got your choice of Curious George or Dr. Seuss. They've got little kids. And she started talking about when her kids were little, and then her grandkids, and we never got to the story. But we brought her full circle. We brought each other full circle, standing on that horizon with the inevitability of life. And after about 20 minutes, she was chuckling and crying, and we were both doing that. And she said, I think I'm going to be able to go to sleep now. And I said, okay, me too. And she died about a week or two later. And I would offer that was the most transformative clinical experience as a physician I've ever had. And it had absolutely nothing to do with medicine. It was having the courage to come to that space and stand right beside and make a difference. So how do we do that? How do we stand side by side? If we reflect on how great change and liberation has occurred throughout history, I can't help but think of this gentleman, Gandhi, and that in the last century, he was asked by colonial England if it was his belief that they would just peacefully exit India, for which they ruled over. And he said yes. And I often thought, how did he know? And it is very, very simple. He stood side by side, hundreds of millions of country persons, advocating for a positive, advocating for self-rule, autonomy. He did not go toe-to-toe with England, not antagonistic. He was for something, not against something. Throughout my career, I've learned that if I stand beside a patient and I advocate for what is sacred to them, have the courage to share with them the absolute reality of what's going on, good, bad, or indifferent, that it's going to be a success. It doesn't mean that we beat cancer. It means that they're able to live their lives and we can care for them predicated on their values. Early in my career, I had a woman I was caring for at home who had recurrent breast cancer that had metastasized to her brain. She was in her late 70s, and she said, Doc, I want to stay here. I want to be comfortable. I can get it. I'm going to die. I don't want any of those shenanigans. Okay, we'll do what we can. Her son came to visit and stay with her. He had an acute event, meaning one night, and it happened to be a Sunday evening, she started having severe chest pain and shortness of breath. She couldn't breathe. And her son called 911. Why? He was scared. Did he do anything wrong? Absolutely not. They take her to the emergency room. The emergency room physician says, "What's the problem?" "I'm having chest pain. I can't breathe." So instead of looking at her chart and seeing on the first page he had a recurrent, widely metastatic cancer, he called cardiology. Cardiologist comes in. Quick evaluation, chest pain, shortness of breath. Some of her enzymes are elevated, which may be consistent with something going on with the heart, maybe not. And again, he failed to look at widely metastatic recurrent cancer. And he walked in and he said, "Do you want to die?" I've never known anyone around the globe to say, "Yeah, pick me, that's fine." He said, "No." He said, "Then I have to take you to the catheterization lab." I came in Monday morning a little before 6. It was on my list of patients, and she was in the intensive care unit, and so I went down there. He was on the verge of respiratory failure, meaning a fork in the road of keeping you comfortable and you will die because your lungs will cease to work, or keeping you comfortable and then put a big tube down your throat and hook you up to a machine and you will die because your body is actively dying of widely metastatic cancer. I contacted the cardiologist, explained who I was and what was going on, and I heard the phone click. And I called him back. Started to explain again, and I heard another click. 2 minutes later, the individual presented in the intensive care unit. We went to a side room, and I explained that she was able to express she did not want to be intubated. She wanted to go home and be comfortable. The same things she had expressed to me many, many times when I had visited her in our house. His response was, I asked her if she wanted to die, and she said no. I said, well, I think it's the wrong question, because she is actively dying, and you should ask her how she wants to live in this setting. His next comment was, she has negated her do not resuscitate, so we could do the catheterization. I said, well, she can rescind it again because she doesn't want to be resuscitated. He said, I am not going to allow that because it will go against my 30-day mortality. And I looked at him, and the first impulse was to meet him on the playground after school. I said, this is not about you or me. At which point he said, I hope not, because all you do is euthanize people. I took a deep breath and I said, it's really about her life, her journey, her legal rights to make a decision. In a tempest, he left the ICU. We got her home, and she died the next day, surrounded by family. Comfortable. If I had gone toe-to-toe, the outcome might have been very different. And while I wanted to go toe-to-toe, our role is to support each other as human beings, and to stand side by side, espousing the truth, listening and hearing, and taking one step at a time together. And that's what this bigger conversation is about. Going from Rembrandt to Pollock, slaying our dragons, living our lives. Months before my mom died, she was able to articulate, as she had so many times in her life, she wanted to be at home, surrounded by friends and family, and good Scotch from Ireland. And the reverent Irish woman she was, He said, this needs to be a celebration, not a mourning. And so I would encourage us and challenge us to think about Jackson Pollock, to think about embracing the unknown, walking to our horizons, seeking the truths that we can come back and share with others. That's how we change the culture, that's how we change the system, and that's how we live. That's what I wanted to share with you tonight. And I would love if there are questions, comments, concerns, philosophical observations. This is a uniquely human experience, and I would encourage us all to embrace it. Well, thank you.
So, are there any questions? The question is, how do we find a doctor like you?
Oh, geez. Well, I think it's about advocacy. I think we have to understand, first of all, let me see if we can do this. Can people see me? Is that better?
Yep, we can see you. I'll make your screen bigger on our end.
God, don't scare everybody. I think we have to recognize, again, what is inevitable. We have to recognize that physicians, anybody who says, you know, I don't know what's going to happen, it's going to call, you know, baloney on that. We absolutely know what's going to happen. We just may not know when. We know what's going to happen, and you need to be empowered with the truth so you can make a decision on how you want to move forward. You know, at the end of the day, if we keep it just to healthcare, you are a consumer at some level. And years ago, when I went to my mechanic, and I showed up with a Honda Accord that had 300,000 miles and 4 rolls of duct tape, I said, Frank, what is it that I need? And everybody knows, he said, Tim, you need a new car. I said, well, I can't afford a new car. He said, all right, so what do you need with this one? And I said, well, I need to get through the winter. He called me back the next day and he said, there's 100 things wrong with your car. If you want to get through the winter, we have to get new tires and one other thing. And 98 things may come into play. And if they do, let's have a conversation about it. But pursuant to what your goals are, you have to do these 2 things. I get more information from my mechanic than we get from our physicians, and that's wrong. So we need to advocate and know that there's a different way and hold each other accountable to advocating and demand the truth. Well, that's how you get physicians that are going to stand side by side.
Other questions? Oh, yep, just a second here.
What's the difference between palliative and hospice care?
Nobody knows, but I paid her to ask that. So thank you for asking that. At a very high level, everything hospice is palliative, but not everything palliative is hospice. Hospice is really a governmental definition of 2 physicians think you have less than 6 months to live, and it's a Medicare insurance benefit, right? And it's way down over here on the end of life. Palliative care is something that can be delivered concurrently with curative care, so aggressive chemotherapy, surgery, whatever. It's an expertise in symptom management. It is way upstream at the point of diagnosis. So I mentioned I cared for people for many, many years. Some of them, you know, a friend in Des Moines went into remission and are recovered now. So palliative is for any individual dealing with a serious and more than likely potentially life-limiting illness. In addition to understanding how to care for the symptoms, it is the highest level of clinical acumen to look across 1, 2, or 3 disease states, know what the interaction is like, know what the journey is going to be like, and set up a care plan to meet those closet monsters because they're going to be inevitable. And then to translate across oncology and cardiology and pulmonology and kidney doctors to the bedside so that you have a clear understanding of what's going on. And then to couple that and overlay it with what is that little voice in your heart telling you? That is true palliative care. Hospice is a component of that way down at the end of life if someone chooses to engage in the Medicare insurance benefit entitled that, fraught with restrictions, fraught with certain diagnostic criteria. That's hospice. And hospice is a wonderful value. But palliative medicine extends years in front of that and can be delivered, again, concurrently with curative treatment. And we know that people live better and longer with true palliative care, period. Does that help?
I think that answers the question. Are there any other questions? Got another one coming.
Doctor, is palliative or hospice care different in a nursing home environment than it would be if you were at home or in other circumstances?
Did I lose you?
We've got you. Did you hear the question?
I didn't. I'm sorry.
Okay. Doctor, is palliative or hospice care in a nursing home setting different than it is if you have someone in their home? Because I'm an advocate at a nursing home. I have dying patients, and I'm having issues with getting adequate pain medication in spite of hospice being involved. And to me, this is disturbing.
No, it's a very, very insightful comment and question. The answer is that true palliative care is unique to the individual that you are engaged with. So is it different? It's different for everybody. It's predicated on what somebody desires, what their goals are against the backdrop of what they're dealing with. Did we deliver palliative medicine and long-term care? Yes. It empowers practitioners within that facility to practice A, to the top of their license, and B, when you bring forward the discussions about what's important and you put that down in the care plan, then you can treat through that. So someone who has pain, we can set a care plan that acknowledges that and treats that. And there's no fear of regulatory compliance or financial penalties because you've got a care plan that's been discussed, everybody's been brought in, and you can truly care for the patient one day at a time. And with telemedicine and access to these types of providers, you know, Aunt Martha starts to have pain at night above and beyond what she's had before. The knee-jerk reaction historically, and really continues to be, send Aunt Martha to the emergency department. It ain't where she wants to go, and it's not going to be beneficial to her in the long run. True palliative medicine integrated into long-term care, skilled nursing, independent living, homes, etc., has the ability, with the right providers and right mindset, to come and deal with those symptoms. You know, and in addition, we know that 60 to 80% of all long-term care inhabitants have untreated pain, particularly in your dementia population. They can't express it. And so if we're able to come in as palliative providers or someone with high clinical acumen and understand what that is and treat it, they're not going to fluctuate up and down and up and down and up and down. They're going to be consistent, and it's going to be quality, and they're going to live longer and better. So that's how it can be utilized in long-term care. To the point of, is it different? I would offer the philosophical foundation is not different. It's how you utilize your resources and empower people in the long-term care facility to be your partners and to carry out plans that are persistent with that particular patient.
Do we ask our primary care for specialists insist on one and hope they'll work together?
Was the question, can we ask primary care and specialists to work together?
Yeah. So how do you go about getting this kind of care? Like, how do you get a specialist? Do you just ask your doctor? You know, how do they make that happen?
Another great question. Yes, you are the patient. It's your life. Again, if we frame it as you're the customer, the consumer, if you say that's the type of care that I want involved, no matter what anybody says, you demand it. Most primary care physicians and other types of specialists don't have a true understanding of what we're talking about here tonight. They may say, oh, you're not ready for hospice. Well, we're not talking about hospice. Well, you're not ready for that, or my patient's not ready for that. No, I'm not going to do that. I've had patients' families, the primary doctor said, no, I'm not going to do that. No, it's your legal right. If you want to see a particular type of physician, you demand it. I think the inexorable challenge is that it's a small fraction of providers, physicians, nurse practitioners, DOs, PAs, etc., who wear the coat that says palliative physician that ascribe to this philosophy we're talking about tonight. And again, we're in our infancy, so even in the context of, well, I've got a palliative care team or a palliative care physician, one need be wary of what their resource limitations are, what the system is ascribing them to do, because it's not always, making you as a patient at the center of the conversation. So I would, and I hate to say this, but it's approach it with some skepticism. If it doesn't resonate with what that little voice in your heart is telling you, challenge it, seek something else, seek something different, because that's really the only voice and the only prognostic factor that has any truth. So you have to hold them accountable.
Anybody else? Okay, I think that looks like it's it. So go ahead, Hannah, you want to close off?
Let me share one last thing with everybody, please. Part of this building community and caring for each other as human beings. If they pass out my contact information, if you have questions, please reach out. I'll do my best to personally answer them within a few days. If you don't hear from me, send me another email. This is about changing the conversation horizontally and vertically. And I would enjoy and encourage the connectivity and the dialogue. And I thank you for not falling asleep and listening to what I have to share this evening.